Good evening to everybody, and thank you everybody for giving me an opportunity to participate in the web seminar. At the outside, I am very much thankful to Dr. Jwale, Dr. Ravi Kumar for giving me the opportunity. And today, my topic is antithrombotic treatment in COVID-19 infected patients. Okay, so already Dr. Jwale and Dr. Amish Sharma talked about the complications, presentations of the cardiac symptoms due to COVID, and also management of acute MI in COVID patients. I am talking about only the antithrombotic treatment, that is the management of COVID patients. So you know the implications of COVID-19 on CVD. So COVID-19 with the vast cardiovascular implications, it increased the risk with prior cardiovascular disease. Not only with the prior cardiovascular disease, without prior cardiovascular disease also it will increase the cardiovascular mortality due to the thrombus formation due to COVID, due to inflammatory reaction or the severity of the illness itself. So COVID-19 with the vast cardiovascular implication increase the risk for adverse cardiovascular in those with prior cardiovascular disease. Also, individuals without a history of CVD are also at the risk of incident cardiovascular complications. The direct effects of COVID-19 or the indirect effects of infection such as to severe illness and hypoxia may predispose patients to arterial as well as venous thrombotic events. The hemostatic abnormalities with the COVID-19 include mild thrombocytopenia and increased D-dimer levels, which are associated with a high risk of requiring mechanical ventilation, intensive care unit admissions, or death. I think Dr. Jawale, you got the information by this sentence actually, because those who got an increased level of D-dimer thrombin level, there will be always a risk of death, and as well as the patient going into the mechanical ventilation or some sort of sepsis or complications is more. Disease severity is variably associated with the prolongation of the prothrombin time, INR, TT, and also there will be shortage of the decrease of APTT.
Next slide.
Yeah. The severe inflammatory response. This is just before going to the proper topic. I am giving you how the patients will develop thrombosis of both the veins and arteries. The severe inflammatory response, critical illness, and underlying traditional risk factors may all predispose to thrombotic events, similar to prior virulent zoonotic coronavirus outbreaks. Investigation therapies for treating COVID-19 may have adverse drug-to-drug interaction with the antiplatelet as well as the anticoagulants which we are using in COVID patients. The study summarizes the treatment related to thrombotic disease in patients with COVID-19. It also highlights management of thrombotic events in patients without COVID-19 during this pandemic. So I am talking about both antithrombotic treatment in COVID patients as well as non-COVID patients. Okay. This is the postulated mechanism of coagulopathy and pathogenesis of thrombosis in COVID. I think already discussed in detail. So the risk factors, the acute illness, bedridden, fever, diarrhea, sepsis, liver injury, kidney problems, COPD, heart failure, malignancy, and then inflammatory response, endothelial dysfunction, and the superimposed infection. That all markers which leads to hemostatic abnormalities in our body like pulmonary microthrombi, intravascular coagulopathy, myocardial injury, and increased cardiac biomarkers as well as other D-dimer, fibrinogen degradation production of prothrombin type and decreased platelet count. This will leads to venous thromboembolism, myocardial infection, and DSA. I think this is one of the worst complications in the COVID patient. The mortality is because of this DSA, and the second is the myocardial infarction. Okay, next. Then these are the, I think everybody that antithrombotic treatment contains antiplatelet as well as the anticoagulants. So variety of antiplatelets and anticoagulants, how they will act, and the pathway they are used, the drugs used to block this one coagulation pathway. This is the intrinsic and extrinsic pathway. So different drugs act at the different level, especially Iveraxaban, Apixaban index, and at the XA, there is intrinsic pathway, extrinsic pathway, heparin, warfarin, and fundaparin, indaparin, hydrodin, buradin, aglutapin, dabigatran. And basically thrombin and factor XA acting, they will block this one. There are different drugs are there to block the thrombin, that is factor 2A as well as the factor XA. Okay, next. And these are the site of action as well as the time to peak action, half-life, and dose administered during cardiac event, thrombotic events in COVID patients, and the route of administration. I think everybody knows this one, this slides, dose and all. I don't want to go into detail. Next. So this is the, I think, important slide, because nobody will have a time to go to check the INR, PT INR, and also regularly maintain the normal level of the range, INR in the therapeutic range of INR. So to avoid that, I think nowadays everybody will advise new oral anticoagulation, direct thrombin inhibitors, direct oral anticoagulations. I think this is just a general recommendation, sir, in which conditions you have to prefer which NOAC drugs. Like a high risk stroke, if there is an high risk of stroke, you should usually prefer dabigatran, the dose of 150 mg BD. And if there is a previous stroke, I think rivaroxaban, a dose of 20 mg OD. High risk of bleeding or previous life-threatening bleeding, again dabigatran, and also apixaban you can prefer. Dyspepsia, rivaroxaban, apixaban. And there is a GI bleed, apixaban, that is 5 mg BD dose. I think dose regimen also it is mentioned here. And there is a medical compliance problem. Some people, those who are not able to take BD, I think you can go for rivaroxaban. There is a OD dose. And elderly, there is a more than 80 years, and if there is a renal dysfunction, I think you can prefer apixaban at a lower dose, 2.5 mg BD. Next. And this again dosing of NOACs according to the renal as well as the liver dysfunction. I think we can go through the slides. If there is a renal clearance is less than 25 to 30, I think you should avoid drugs like dabigatran, rivaroxaban, and enoxaban. You can prefer apixaban with a lower dose at 2.5 mg BD. Next. So these are the drugs what you are using in thrombotic management of COVID patients. Next comes to the markers of myocardial injury, already explained, and as well as the thrombotic disease in the COVID patients. So this is the elevated troponin levels, not only due to myocardial infarction, it can be due to other reasons like impaired renal function, pulmonary embolism, and myocarditis. So before managing any myocardial infarction, I think we have to rule out any the elevation of troponin may be due to myocarditis or some other else, or you can do an echo and to look for region of motion abnormality before taking decisions. And the elevation of natriuretic peptide, I think you know that it will be to cardiac failure due to myocarditis, that will lead to global hyperkinesia and LV dysfunction that will increase the natriuretic peptides. Okay. This is the investigation therapy. I think you know the certain drugs which are used in COVID patients. That is the investigational drugs actually. They are not specific for COVID patients. This will interfere thrombotic events. It can increase the thrombotic events, or it can produce thrombocytopenia. Or certain drugs it can helpful in reduces the reperfusion injury. The fingolimod reduces the reperfusion injury and improves outcomes in patients suffering from acute ischemia. And hydroxychloroquine can produce arrhythmias, sudden arrhythmias and sudden cardiac. At the same time, it can exert antithrombotic properties, especially against antiphospholipid antibodies. So before starting any treatment, new investigation treatments in COVID patients, you have to think about the drug interaction with the antiplatelet and anticoagulants. I think next 2 slides I will show you which next. So this slide will give you an idea about drug interaction with antiplatelets. So here, these drugs that new COVID investigation agents will block either block or induce a metabolic pathway, so that it will either decrease or increase the our antithrombotic agents metabolism. So that you should either sometimes you should reduce or should stop or should modify the drug dosage. So that's why you should know about the drug interaction between the new COVID agents as well as the antiplatelets. Next. This is also the same thing. This is the oral anticoagulation, dabigatran, apixaban, and endoxaban. So same like antiplatelet. This is also oral anticoagulation. Drug interaction between these certain drugs, no need to change. In certain situations, you have to change, modify, or you have to reduce the dose. Next. This is comes to the proper topic, that is venous thromboembolism. First is I'm talking about prophylaxis in hospital patients. Prophylaxis. Any patients who are before starting the treatment, he should do the risk stratification. Means normally you know that everybody who got admitted with COVID, they will have a high risk for venous thromboembolism due to acute illness like pneumonia, bedridden, and any active malignancy, earlier active malignancy, like liver dysfunction or kidney dysfunction. There are the precipitating factors which will increase the venous thromboembolism in COVID patients. So that's why we should treat all the patients, those who got admitted with prophylaxis with either low molecular weight heparin or unfractionated heparin. Usually you should give low molecular weight OD dose. Unfractionated heparin should give BD or TAD doses. Normally they will prefer BD dose, 5,000 international units BD dose. Low molecular heparin OD, because normally you will prefer low molecular heparin because it will avoid wearing repeatedly PP kit and exposing to the health workers to the COVID patients. Usually prefer low molecular heparin instead of the unfractionated heparin. And if there is a contraindication for pharmacological treatment, you can like intermittent pneumatic compression. So to avoid developing the DVT in the cough muscles, and that leads to the embolization. Next. Again, this is after discharge. This is the admitted patients, COVID, those who got admitted in the hospital, we had to use VT prophylaxis. So this is after discharge, how long you have to give, or whether really you should give the VT prophylaxis for all the patients. It is not like that. Usually, if you should give for 45 days from the hospital date of discharge, and only VT risk patients only you should give prophylaxis. Like I mentioned, at high risk, like including those who have limited mobility and history of prior VTE or active malignancy. So these kind of patients you should give VT prophylaxis because there is a risk of bleeding. You should match or compare benefit of the VT prophylaxis. Those who are getting a high risk of thrombosis, like I already mentioned. If there is a risk of bleeding more, I think you should totally avoid this prophylaxis treatment. So always risk-benefit ratio you have to see before starting the VT prophylaxis. And the diagnosis of VT in hospital admission, Dr. Juwala already he mentioned, you cannot shift the patient for CT scan, and you cannot do the echo or ultrasound, bedside ultrasound, but still the clinical suspicion is enough to diagnose and treat the patients, treat the COVID patients. Like clinical suspicion like deep vein thrombosis symptoms and hypoxia, which is disproportionate to known respiratory pathogens, or acute unexplained right ventricular dysfunction. If it is there in the patient, I think you can go ahead and do the management, treatment, give the treatment for VTE. And one may consider echocardiography to rule out RV dysfunction as well as the clot in the main pulmonary artery branches, so that we can, instead of going for CT, you can, on this basis, echocardiography basis and clinical suspicion, we can treat the patients of VT. So role for empiric, that means role for empiric therapeutic anticoagulation without a diagnosis of VT. Yes, some clinicians use intermediate or full dose parenteral anticoagulation for routine care of patients with COVID-19, hypothesizing saying that it may confer benefit to prevent microvascular thrombosis. The majority of panel members consider prophylactic anticoagulation instead of going for intermediate or therapeutic dose for VTE patients. The medical therapy of VTE, this is all the prophylaxis, and come to the now proper management of VTE. Here, intermediate submassive pulmonary embolism cases, hemodynamically stable cases, we can just give anticoagulation treatment. No need for thrombolysis or catheter embolectomy or surgery. Those who got a hemodynamically unstable, severe pulmonary embolism cases, very sick cases like hemodynamically unstable RV dysfunction, you have to go first. You can go ahead and do the lysis, systemic lysis. Or if there is a contraindication for systemic lysis, you can go for catheter related treatment or surgery. This is the flowchart of the same what I told you. Medical therapy for VTE you can give for parenteral anticoagulation. That is usually. Another thing is here I forgotten to mention in the previous slides. Parenteral antithrombotic treatment they have got a less drug-to-drug interaction with the COVID-19 therapy. Therapies, new COVID-19 agents. So always I think you can prefer low molecular heparin. But if there is if you're thinking that if you are doing some procedure, I think better avoid low molecular heparin and can use for unfractionated heparin. And direct oral anticoagulation, there is a new oral anticoagulation always is preferable, and because it's a safe, no need to do any monitoring. Only thing is availability is a problem actually, and cost is the problem. Otherwise, it is a good drug, and also it is a very safe and effective drugs. Then vitamin K antagonist, usually nobody will prescribe this vitamin K antagonist after discharge because checking the INR frequently have to check the INR to maintain the target, to maintain the PT, to maintain the INR in the range, therapeutic range. So that is the problem, especially because otherwise you have to expose to the COVID patients. There is always risk of exposure to the COVID patient. That's why we'll avoid vitamin K antagonist and prefer direct oral anticoagulation. In case if you are not able to take direct oral anticoagulation, you can always go for a single dose of low molecular heparin even after discharge as a prophylaxis. So selection of agent requires always consideration of comorbidities such as renal or hepatic dysfunction, thrombocytopenia, and gastrointestinal tract infection. I think already gastrointestinal tract function. I already mentioned which drug you have to prefer in renal or hepatic dysfunction or thrombocytopenia or any dyspepsia in the previous slides. This is same thing. If you maintain the INR at the stable level for 2 to 3 months, I think you can avoid frequently checking PT-INR. I think you can postpone instead of monthly checking. You can go for 2 to 3 months. Every 2 to 3 months, you can check the PT-INR. If it is stable, previous 2 to 3 readings in 2 to 3 months, if it is stable INR, then you can do that. Suppose if you are able to get at home INR checkup by yourself, and or you are able to drive through INR testing schedule, or you can, if you visit a schedule office or lab visit during off peak to avoid exposure to the COVID patients. If you are able to do all those things, I think always you can go for warfarin or there's oral anticoagulation, no? Indirect oral anticoagulation. Or if it is not possible, again, if there is no contraindication for direct oral anticoagulation like valvular AF, mechanical valves, APLS, pregnancy, breastfeeding, these are contraindication. If it is not there, you can go for a direct oral anticoagulation. If there is a contraindication, again you have to go for same indirect oral anticoagulation like acetylene oral warfarin. And before switching from direct to indirect oral anticoagulation like acetylene or warfarin to new oral anticoagulation, you should, your INR should be 2 or less than 2. That I think you should remember. Come to the ACS in COVID-19 patients. The antithrombotic therapy for ACS, I already mentioned, type 1 MI, that is due to rupture, plaque rupture, should use, treat the patient like according to the ACC and AHA guidelines as well as, and also ESA guidelines. Like previously, without COVID patients, how we are treating, you have to treat like that medically. And as I said, Dr. Amit Shah told that to prevent exposure to the COVID, not only the doctor, other medical team also, staff members also, I think go for direct thrombolysis. This was there earlier actually. Nowadays, everybody, if preferring primary PTCA, if the patient is in, if they comes within the range, reachable type, go for primary PTCA after very PTCA. And second thing is, if it is not feasible, like if there is no thrombolysis, then you can shift the patient to the higher center where the either this is available. And other thing is, if you give thrombolysis and if the patient
There is a disconnectivity.
Still having ongoing pain, arrhythmias, refractory failure, the same thing about the antithrombotic treatment. Intensive image, I think I already mentioned the same thing. Next slide.
Call me later on.
Yeah, this is the summary of the antithrombotic treatment in all COVID patients. So mild COVID outpatient, that is a house quarantine patient. So you can give, you can continue the whatever the previously taking antithrombotic treatment for chronic coronary heart disease conditions. So you can continue because it won't cause us or aggravate the COVID infection in those cases. You can always continue. And VT prophylaxis, it depends upon the VT risk score. If they got immobility, I already mentioned, you can always start VT prophylaxis at home also. If there is no VT risk factors, no need to give VT prophylaxis at home in mild cases, house quarantine patients. Next thing is moderate, severe COVID patients without a DSC. Here, all the patients should receive VT prophylaxis, especially single dose of low molecular heparin or BD dose of unfractionated heparin. But some people will consider a therapeutic or intermediate dose of anticoagulant agents. That is, as we are routinely using BD dose of low molecular heparin and 6-hourly unfractionated heparin. But that is very few people only will consider that type of treatment. And patients who got a moderate or severe COVID-19 and suspected or confirmed DSC. I think this one I am a little bit give more in details. I am going in depth actually because this is Dr. Joy asked about this DSC. Here also you have to give low molecular heparin prophylaxis to prevent thrombus formation or progression of thrombus. We have to use the low molecular prophylaxis. And the other thing is usually precipitating factors are very important here in DSC, like any infection, pneumonia, other things you have to treat the underlying and treatable causes. So that is very important in DSC. Third thing is platelets. If it is not indicated, really indicated, like if there is a previous MI and previously patient undergone angioplasty, those cases should continue antiplatelet, but other cases it should not, normally you should stop the antiplatelet. And you can prefer less bleeding complications antiplatelet like clopidogrel. You can low dose of clopidogrel, you can continue. But what this is, usually if it is not indicated, you should avoid antiplatelet. And in those cases, like those who are undergone angioplasty or previous, if there is an MI, in those cases, if you are giving antiplatelet, you should look for platelet count. If it is more than 50,000 dual antiplatelet, you can continue. If it is 50,000 to 25,000, single antiplatelet. Less than 25,000, you should avoid stop this one antiplatelet using, because there is a risk of bleeding complications in those cases. And blood products you can use before taking the patient for any invasive procedure in those cases, because they will have a lot of bleeding complication during invasion because the PT, APDT, all those will be prolonged. You can give this one, what is that, prothrombin complex concentrate or FFP, platelet transfusion. Always you have to maintain more than 50,000 platelet count when you do the invasive procedure in this situation. Next is
how many more slides? Time is ticking away. Dr. Kumarswamy.
2 slides are there, sir.
Okay.
And patients with COVID-19 presenting with ACS and VTE, you already know how to manage and all. Patients without COVID-19 who have previously known thrombotic disease, you should continue. You should not bother about whether you will get a COVID-19 infection compared to the other patients who are not taking antithrombotic treatment, or COVID-19, if you get, it will become very severe. Don't bother about that. You continue antithrombotic treatment. And patients without COVID-19 who develop new thrombotic disease, you have to manage like non-COVID like patients only, according to the guidelines. And patients without COVID-19, but with comorbid conditions like prior VTE, you should take VT prophylaxis. Even though there is no cardiac illness or no other cardiovascular disease, you should take VT prophylaxis if there is a VT risk. And this is the summary: high risk and high risk ACS, VTA, and low risk COVID patients, and low risk ACS or VTE with high risk COVID. This table gives you a summary of the management of COVID patients. Okay, next. This is again the same summary. Last is so more data and higher quality data are required to learn how COVID-19 and thrombotic disease interact. In conclusion, thrombotic disease may be precedent factors or incident complications in patients with COVID-19. Important consideration for the preventive and therapeutic use of antithrombotic agents should be kept in mind to mitigate the thrombotic and hemorrhagic events in the high-risk patients. Funding agency, professionals, societies, patients, clinicians, and investigators should work collaboratively to effectively and efficiently address numerous critical areas of knowledge gap. And thank you very much.